Hello, my presentation is on the following research study referencing the center of rotation of the talus to restore tuber length in anatomic reduction of calcaneus fractures. This project is a research study coming out of the Department of Orthopedic Surgery at Wayne State University. We have no disclosures. So just a basic introduction to calcaneus fractures. Calcaneus fractures are a very challenging fracture pattern to treat surgically. Pretty rarely 1 to 2%. However, when they do occur, they're pretty challenging to treat, as a lot of them can be interarticular, up to 75%. Now, normally with the mechanics of a traditional calcaneus fracture, what happens is the calcaneus will shorten, will widen, and then also the calcaneus will be pushed into varus, meaning distally the calcaneus will be kind of turned inward. Now, in terms of surgical fixation for calcaneus fractures, these are usually fixed with surgery, almost always operative, either closed reduction with percutaneous pinning or percutaneous fixation, or open reduction internal fixation with plates and screws or some sort of construct. And traditionally, the quality of surgical reduction and the height of the calcaneus, which is important for its biomechanical function, will depend directly on the restoration of Bowler's angle, which we'll abbreviate and call BA, and the tuber length. Now, we'll talk a little bit about what the tuber length actually is. Now, the gastrocsoleus complex, which attaches to the Achilles tendon, and its force, which is transmitted to the calcaneus tuberosity, causes the ankle to plantar flex around the center of rotation of the talus, the COR, which we'll use as an abbreviation later on. Now, the moment arm of this whole equation is the Achilles tendon on the calcaneal tuber, as I said. And you can kind of see that in this image here, where this is where the Achilles tendon attaches, and then the rotation is kind of around this point where the calcaneus actually moves. Now, as I said earlier, the Bowler's angle, using that to as a marker for successful reduction, is traditionally has been seen in the literature to be associated with a lower risk of subtalar arthritis and overall morbidity and better functional outcomes after fixation for calcaneus fractures. Now, usually what the literature says is that the Bowler's angle should be between 20 and 40 degrees. That's the range of normal physiologically. However, it is important to note that usually people have a very similar Bowler's angle bilaterally on both calcaneuses. So ideally, a successful reduction should improve that angle to be very similar within a very close range of the contralateral Bowler's angle. Now, the purpose of this study is to define the center of rotation of the talus, assess the tuber length after the reconstruction of the calcaneal tuber, and assess its influence on the height of the calcaneus and also the work on the Achilles tendon. Now, our hypothesis is that a shortened tuber length may cause an increase in work of the Achilles tendon, which would result in a biomechanically inferior reduction. And essentially, that's what we are trying to further investigate. Now, here's just an example of the two different types of fixation you can do with calcaneus fractures. You can either do an ORIF or CRPF. In terms of our methods for this research, this is a retrospective study at a single level 1 trauma center. Over the course of 10 years, we had 345 operative calcaneal fracture cases. 39 of them had adequate x-rays of both feet that we could use. Now, what we did is we took these x-rays and we used the Detroit Bone Setter app, which is a useful app that is used to look at different biomechanical markers, x-rays. So we use that to find the BA, the COR, as well as the tuber length. The moment arm of the Achilles tendon was defined as a distance between the tendon insertion to the COR, the talus. And that's what we call the TL. Now, this is actually what the TL measurement is. Again, this is the center of the talus. So what we do is we draw a circle right along the dome of the talus. And then the center of that circle to the most posterior aspect of the attachment of the Achilles tendon that you can kind of see with this black shadow is the tuber length, also known as the moment arm of the Achilles. Now, this is actually the BA measurement, Bowler's angle. Essentially, you have three different points right here. You have this point right here on the tuberosity. You have this on the anterior process, and then this point right here. And using these two lines, you can actually calculate this angle. Now, what we did is we looked at the BA and the tuber length for each ankle, and we compared both sides, both the normal calcaneus and the injured calcaneus. And just, thinking about, what work actually is, right? Because we're thinking about biomechanically, what is work? It's the product of force times distance. As you can see in this image right here, using the tuber length as our distance, if the force is basically a constant force of the Achilles tendon, we can kind of conclude that a shortened TL will result in an increased work on the gastrosoleus complex. Now, we went ahead and did statistical analysis to find the average postoperative and contralateral tuber length. We separated for ORIF versus CRPF. We also separated into short versus restored TL based on it was over 0.4 centimeters. And then we separated them into good reduction based off of whether their postoperative Bowler's angle was less than 5 degrees different than their contralateral angle. For our results, we had 39 cases that had good postoperative lateral weight-bearing radiographs, and 18 of these underwent ORIF, and 21 of these underwent CRPF. Now, the average tuber length was 5.72, and the contralateral tuber length was 5.99, with a significant p-value here. And essentially that shows that there was an average of 4.48% increased gastrocsoleus work in all patients compared to uninjured limb. Now, 4.48% might not sound like a lot. However, on a day-to-day basis, roughly 4 to 5% increased work on the gastrosoleus complex can lead to fatigue, discomfort, pain, and so it can be a pretty substantial number. Now, we found this increase despite the BA falling within acceptable postoperative standard of 20 to 40 degrees. And as I said earlier, work and tuber length are interchangeable, as tuber length is a factor of work. We also found that ORIF had a shorter tuber length compared to CRPF, although traditionally the literature has shown that functionally the outcomes are similar with CRPF versus ORIF. 8 of 39 patients had shortened TL despite adequately restored Bowler's angle. Now, most of the reductions within our cohort actually fell into the good reduction category because they were pretty close to the contralateral side in terms of the angle. However, 5 of them still fell into that short tuber group. So it means that they still had increased work of that gastrosoleus complex. And then in the acceptable reduction group, 3 of the 13 were also the short tuber group. So kind of just some takeaways. While Bowler's angle restoration has been kind of the operative marker for success traditionally with calcaneus fractures, it doesn't always really consider the change of mechanical work of the Achilles tendon, and that might actually be a better indicator of the functional length of the calcaneus. This study shows that you, in fact, can have increased work on the Achilles when the tuber length is shortened, even when the reduction has adequately restored Bowler's angle. And so final recommendations is finding COR and referencing it to measure TL compared to the other side should be used as an additional goal for restoration of Bowler's angle, anatomic reduction, and deformity correction. And then further investigation is needed, especially with subjective measures, using pain and function and range of motion to understand how that will kind of correlate along with shortened tuber length. And that's it. Thank you.